For those of you who don't, I can't imagine anybody here doesn't know Dr. Joven and Dr. Alexandrov. But Dr. Joven is chairman at Cooper University. Dr. Alexandrov recently started his role of chairman at University of Arizona and the Banner Healthcare System, and really looking forward to this conversation. Thank you so much. So Tudor, I'm going to hand you the mic and I'm going to sit down and.
Okay, and I'm just going to preface this by saying that I'm the junior chairman because we have the veteran chairman here has a few years over me. I've just been doing this for 4 years. So you should listen to him, not to me.
All right. Thank you, Kristen, for organizing this. I can tell you why I became the chair. Because I got tired of being represented by other people who don't understand what we do. No offense to our other neurology colleagues, but when you deal with stroke, and if you're led by non-hospitalist outpatient doctor, that's where disconnect occurs. And taking care of what hospital needs is far different from organizing outpatient clinic and different services. And so I reluctantly volunteered to become a chairman just because I needed a better understanding of much broader needs of all my colleagues. And it's not only stroke and the vascular, neurocritical care, epilepsy. It's everyone who takes care of patients in the hospital and beyond. So modern departments of neurology are all affiliated with hospitals. So one way or the other, there was a tendency over the past 15 years, more stroke doctors were becoming chairs for that very reason. And then, of course, we appoint our best colleagues as directors of outpatient clinics and subspecialties, and that's how we handle it.
Yeah, I mean, I think in addition to what Andre says, I think many people have this kind of tendency, you want to have a more active role, a more position of influence, but it also has to be a good fit. It's not that I want to be chair and that's it. It has to be the right place. For me, the right place was Cooper because it also gave me the opportunity to oversee neurosurgery and physiatry, which I think is an important component. I think that these three specialties, especially neurosurgery and neurology, are growing together, and it's very few places where you have the opportunity to influence neurosurgery as well and make them grow together, because I think that's one of the biggest problems. It's a shame that there's still a lot of places that are completely apart in terms of neurology and neurosurgery. And I think where you went, it's also a very integrated place.
Yeah, you nailed it. It needs to be multidisciplinary partnership. You cannot just develop neurology and then neglect needs of neurosurgery and vice versa. So I'm very fortunate that in both institutions I was chair, I had the most dynamic relationship with neurosurgery in particular. So where we're deficient? Well, so let's talk about stroke specific. So once you take care of stroke, you go 24/7, 365, and you need to have all services uninterrupted. That's a lot of commitment. So you better make sure that you have enough stroke doctors, enough endovascular, you have your units, stroke units, you have your neurocritical care units. It's a living organism, and you cannot be a stroke center Monday through Friday and then dump on the comprehensive stroke center on the weekend. So that's number one. Number two, when we do a great job explaining to the patient, you had a stroke, this is your treatment option, this is the type of stroke, you need to do this to prevent strokes. What happens, memory is like this, and the patient leaves, and all of a sudden we find out that they never filled prescriptions. And so continuity of care is very, very important. So you need to have a clinic where patients are brought back and saying, did you fill your prescriptions? Do you remember what kind of stroke you had? So we are fortunate that we have some of the best navigation system. In fact, Banner is one of the pioneers, and what Kirsten is doing with Kandu is just amazing. It's kind of compliment, but we see a lot of times that our follow-ups are lost. They go somewhere else and there is no continuity.
Yeah, I mean, there's many. It's hard to, as Andre said, know where to start. I think we're still in 20th century and where we haven't moved on to the 21st century. We're not leveraging all the technology that exists nowadays, AI, teleconnectivity. I think, care would be much better and more efficient if it was shifted more to home. But yes, at a fundamental level, I agree with Andre that there is no continuity. Patients move from hospital to hospital, and sometimes they get admitted at 3 hospitals for the same problem. Within a year, everything starts all over again, and that's an enormous waste of resources. And following discharge, many of facilities, mine facility, for instance, does not have their own rehab, which is a huge problem. We don't practice integrated care from home, from prevention through to recovery and reintegration. So yes, I do firmly believe that lack of continuity, this black box that we see when the patient gets out of the hospital, and even before they come in, is a huge source of inefficiencies. And patients are lost. I mean, you just have to talk to any of your patients. Just beyond the technical part, how many, what you take Plavix or what's your blood pressure? Just from a human standpoint, what's have been your journey since you, because since Kandu, I kind of started paying attention to these things. And it's amazing. I mean, patients are completely lost. They don't know where to go, what to do, what follow-ups to pursue, what care they need. And that leads to readmissions, more utilization of care. So that's a big component of our inefficiencies in care.
So how do we create new standard of care? Well, the typical cycle requires breakthrough, right? So you need to have some kind of discovery or something so disruptive that everyone is like, oh my God. So mechanical thrombectomy is a fine example. I mean, we were living in a very frustrating world of beliefs and disbeliefs and kitchen sinks. And then finally technology came through and boom, it is one of the lowest number needed to treat. And hopefully now no one is arguing that this should be standard of care. Or it is becoming standard of care rapidly. But then there are situations when you can have increment steps, developing something, and the fact that you got to FDA approval and you got a billing code doesn't mean third-party payers are going to pay for it. So there are other technologies out there that were struggling for 20 to 30 years to gain acceptance. Example, transcranial Doppler. So story of my life. And so when you deal with patients that are needing multiple problems, you need to create a perfect storm. When you have a new advance, and then all of a sudden, not only doctors, not only media, but patients themselves advocate and kind of create that need. I think that's engaging public and the patients is an important part.
Yeah, and to draw the analogy with thrombectomy, I mean, I think we need to go down the same path. How do we create a new standard of care? Very simple, with data, okay? For good reasons. There's still a lot of skepticism as to, the utility of these new approaches, care at home, navigators, these kind of things, prolonging the hospital stay, so to speak, at home. And we need to show that this is effective and ideally also cost effective, because at the end of the day, these standards of care are also created by payers playing along. So without bringing in data into this field and showing that, number one, care is not good right now for most neurological diseases. Once patients get discharged from the hospital or chronic diseases, and that there are ways to improve this care, we need to generate the data to support that.
Quick comment here also, a phenomenon called best practices. So you need to not only promote best practice that someone may be developing or an early adopter took on, but you also need to show cost effectiveness And sometimes that's what hospitals are going to listen to before even more general shift occurs. Because hospitals, at the end of the day, are recipients of DRG. You know that? So it's lumped payment. So whether you do little or you do a lot, it's the same payment, right? So you need to make sure that you use your resources the right way and you achieve better outcomes.
So the deficiencies are an all-day discussion. And then to create new standards of care to address those requires evidence. So there's an enormous amount of work to do. Thank you both so much for your leadership in transforming stroke already and continuing to do it with us. As we talk about deficiencies and ways to address them, what Kandu has developed is a remote multidisciplinary post-acute care program for stroke survivors, combining occupational therapy, social work, physiatry, and neuropsychology to bring stroke survivors the support that they need. There will be a presented poster this afternoon from Dr. Nancy Tsai on our initial outcomes. But in noting the deficiencies, actually, there's now a SpinSights session that Tudor will be speaking in. But Dr. Demetrius Lopez is going to be giving a presentation, Back So Soon, Understanding Hospital Readmissions After Stroke. Some really incredible data on the breadth of the healthcare issues that present after stroke, well beyond just stroke recurrence. So I would highly encourage everybody, please attend the sessions, some really novel, innovative thinking, and thank you all for your time.